and welcome to the Advanced Bionics Roundtable and discussion on the AIM tablet. This is a tool that Advanced Bionics developed to support objective measures intraoperatively and indeed postoperatively. We're very fortunate to have three eminent speakers today. We have Mr. Patrick Axon, consultant D&T surgeon from Addenbrooke's Hospital in Cambridge, who will speak about intraoperative monitoring during the insertion of the electrode array. We next have Professor Douglas Hartley, who is also a consultant D&T surgeon based in Nottingham. And that discussion really will be about the cochlear health application, a postoperative application of the AIM tablet. And finally, we have Professor Joseph Mateus, who is based in Israel, who will really speak about the monitoring of cochlear potentials via the cochlear implant itself. So I look forward to some very interesting discussions, and we will start with Mr. Axon and the intraoperative application.
So Patrick, you've been doing, I know, quite a bit of work with ECoG in terms of intraoperative monitoring during surgery. Could you describe the ECoG signal you're recording and how you do that intraoperative work at all, please?
Yeah, of course, Paddy. So ECoG is an electrical response called cochlear microphonic to the stimulation of the outer hair cells by an acoustic sound, and was widely used in the past and sometimes still used for the investigation of Meniere's disease. A cochlear microphonic can therefore also be used to assess the health of the inner ear environment, and in particular outer hair cell function. It therefore has a potential to assess residual low frequency hearing function during the insertion of an implant, the array into the cochlea. So the setup is quite simple. Before surgery, an insert is placed in the outer ear, in the canal, and so clicks can be played into the ear during the operation at a certain frequency. We usually use 250 hertz or 500 hertz. And as I say, this can be played into the ear at the point of recording. And when you've prepared the ear for the implant to go in, the implant is first placed in its bed, so under the skin, and then the headpiece is attached to the implant, so held in place by the magnet. And when all functioning, that headpiece is then connected to the AIM system, and this then is switched on and records the electrical information as the electrode array is slowly inserted into the cochlea. And it's the tip of the electrode, so one of the electrodes on the tip of the array, that is the recording electrode. And the clicks are played in through the ear canal. This stimulates the residual hair cells within the cochlea, generating a cochlear microphonic that is then recorded by one of the electrodes as it's inserted. And what you normally see as it's inserted is a growing microphonic as the implant is inserted, and then it's maintained over the duration of the insertion. So that's essentially it in a nutshell.
Was referring really to your slide where you showed the block diagram of the recording, and I'm just really making the point, I suppose, you're assuming that now we no longer need to have a needle electrode crossing a tympanic membrane, that it's a much easier thing for the patient and a more practical way of recording.
That's exactly the case. Yeah, we do get with Meniere's disease, when we're assessing Meniere's disease, of course, we don't have the ability of inserting an electrode into the cochlear itself, and so we have to put in a needle electrode either onto the eardrum or through the eardrum onto the promontory of the cochlea to record that electrical information. So no electrodes are required. It's just an insert into the ear canal before one starts the surgery. So it's placed to deliver that click, and then that what would have been the needle is actually the tip of the electrode array recording the activity of the cochlear microphonic.
And so, do you think this is a practical thing to do clinically, or do you see it just very much as a research activity?
Yes, yeah, it's a simple procedure. It doesn't really add very much to the operation in time. It's a very robust response that one is recording. Certainly, in the majority of the cases, occasionally one can't record a response, but the vast majority you can. And of course, it's giving you just the information of the health of the inner ear, the outer hair cells. And so I think any information that you can get during insertion of the electrode array is important. It certainly gives you feedback, which I think does help, but I'm sure we'll come on to that later.
Sure, thanks. And Doug, today you're primarily going to talk about post-operative applications of ECoG, but a surgeon also yourself. Do you have a feeling on the clinical practicalities as you see recording via the implant?
Yeah, I agree with Patrick entirely. I think it does provide a pretty unique opportunity and a very easy opportunity to make these measurements intraoperatively that could really transform what we know about the health of the cochlea through the insertion of the electrode array. So I think it's really exciting.
Okay, thanks. Patrick, how many cases have you actually managed to record intraoperatively?
So to date, we've performed 24, initially as a group as part of a study, but overall 24 patients. And so we've analysed the information on those patients. Yeah.
Nice. And do you think that it's really changed how you insert the electrode array in any positive or negative way?
Oh, it's certainly changed my approach to implant insertion. It's really taught me, I think, how delicate the structures are within the cochlea. One of course expects them to be delicate, and you treat them with great care. But the information that I gained from ECoG measurements had a significant change to my insertion technique pretty much immediately. So yeah, I think it does improve insertion probably in two ways. So the first is that I've slowed right down. I used to insert over probably about a minute for hearing preservation. I've now dropped that down to 3 minutes. It makes me consider tiny movements of the electrode array during the insertion. So I found it important to be as comfortable as I possibly can. So get my arms in the right place, get myself really feeling very comfortable, because 3 minutes is actually a long time. And then I hold the implant in a way that I feel I can probably get the implant into its resting place without having to change the grip on the electrode. And so it can be inserted in one movement. And it does seem that the slower the insertion, the higher the likelihood is that the cochlear microphonic will remain. The second reason is I suppose, more difficult to interpret because we just don't have yet enough information. But when we've performed recordings, we've had instant feedback, usually from an audiological scientist who's been sitting with us. And we learn that this cochlear microphonic grows as the implant is inserted. And that's great. If it's growing, you can continue to insert slowly, and hopefully all is well. But sometimes you can see decline in the cochlear microphonic, or even it can become absent entirely. And so if it declines, then your natural instinct, of course, is to slow down or even stop inserting the electrode array and see if it recovers. And I have lost the cochlear microphonic. and so in those situations, you think, well, maybe I should withdraw a little, just see whether it will return. I've done that. So in short, I suppose it does improve. It has improved, changed my technique, and I suspect improved my technique for insertion. But I don't think there's quite enough evidence to support its instant feedback properties, and I think we need more information about that.
Okay, yeah. How much hearing loss do you feel you've seen with the use of ECoG as a monitoring tool in surgery? I know we have a little graph there of some changes.
Yeah. So well, there's lots of ways interpreting the cochlear microphonic. So as mentioned, you can get a rising cochlear microphonic that really does sort of augur well for hearing preservation, and you can get a plateauing of that cochlear microphonic, which I think probably is the same. Once you've got a strong cochlear microphonic, that's a healthy cochlear microphonic.
Mm-hmm.
It can decline, and you're not sure why it's declining. It might decline, then recover again. And then, of course, you can lose it. So all those different graphs are seen or when you're using the AIM system, and they do seem to link to outcome. So if you lose the cochlear microphonic entirely, then it's likely that you've lost cochlear function, hair cell function. Occasionally, you don't get any cochlear microphonic at all, and I suspect that's more to do with the system itself rather than the health of the cochlear. But in those patients where we have a good cochlear microphonic at the end of the procedure, then we have, on pretty much every case, maintained good hearing. And when I say good hearing, I'm talking about levels where you possibly get, on average, a 13 dB. I think we found 13 dB loss at 250 hertz, and that seems a pretty reasonable outcome for us. Yeah,
that seems pretty encouraging, and I'm getting the impression then that you see a correlation between what the hearing levels are, what the residual hearing is like, and the ECoG measurement that you're making, certainly at the end of surgery.
Yeah, well, that's a different system. So what we're doing is, when we're inserting the electrode, we're recording at one frequency, so at 250 hertz, which is the most important frequency for residual hearing in implants. So that's giving us that instant feedback. And at the end of the procedure, of course, we can record across all the frequencies, and the system, the software, can predict where the hearing is going to be. And what we found is that prediction immediately after the insertion is a very good indicator of what the eventual hearing will be when we test them post-operatively, to within about 10 decibels.
Nice. And really a question maybe to both of you, Patrick and Doug. Do you see this as something that you would choose to use, and maybe what type of cochlear implant case would you use it for monitoring the ECoG?
Shall I go first?
Yeah,
no, that's fine. So I would certainly, again, it goes back to what I said with the benefit and whether it's changed my insertion technique. It's certainly changed my insertion technique, and I do believe, on the back of using it and the information I've gained to date, that my insertion technique has improved. The question then is, do I get real-time feedback during insertion that would enable me to preserve cochlear function, whereas if I didn't have that feedback, I could have lost it, either slowing down, stopping insertion, or withdrawing, maybe repositioning the electrode. And I don't think we have that information. But I think I've got enough information to feel that when I am wanting to perform a hearing preservation procedure using the advanced bionics implant, that I would now favour your Slim J, and inserted incredibly slowly with feedback from AIM, guiding me as to whether I should slow down, continue, or indeed stop and reverse and wait a little while.
I'd agree completely that we should be using these with hearing preservation cases. Whilst we don't have all the answers at the moment, the capabilities of the AIM system could give us some of those answers. It's not as simple as just the speed of insertion. There are many other things going on, but with the capabilities of the AIM system, we might learn more.
Okay. So that sort of brings us naturally on to more of the work. You've been focusing recently on post-operative use of the AIM system, really. Could you tell us a little bit about the type of work you've been doing in terms of the background to that project, please?
Yeah, Paddy. So we've seen the AIM system as, you know, a great intraoperative tool, but we've kind of repurposed the system to be used post-operatively. So for the first time, really, we're able to measure the health of the cochlea in post-operative populations, and we kind of feel that this may help us both better understand variable outcomes, including preservation of residual hearing, you know, post-operatively, but also, and importantly for us, you know, a potential measurement of the safety and efficacy of any adjunctive treatments for cochlear implantation for the future, including cell-based, drug-based, and gene-based therapies. So to do this, we first recruited 15 advanced bionics subjects who'd had their cochlear implants for more than a year. They're all healthy users aged 25 to 75, and we used the AIM device. This was all done during lockdown, so these individuals were given their AIM devices and they made their measurements on themselves at home. We made 3 different measurements with them. First of all, electrode impedances, which is a measure of the inflammatory response, and we're asking them to make these measurements twice daily. Then we also got them to measure their electrically evoked compound action potentials, which is an indication of spiral ganglion cell survival, and we're asking them to do this weekly. And lastly, we were getting them to do echocogliography as a measure of residual hair cell function, and they were doing that daily in the first week and then weekly thereafter. This slide shows the setup that we gave each of the participants. We gave them online training, and this slide is showing one of our participants performing the recordings on themselves at home.
Were you surprised, really, I suppose maybe not totally, that they were able to do this?
The bottom answer, the bottom line is yes, overwhelmingly. I've got a slide here that shows the compliance of subjects. So we've got 15 subjects here that's made measurements over 3 months. And as you can see from the slide, the ECoGs, they were able to make measurements pretty much 100% of the time, as they could with ECAPs. And with the impedances, which was a very intensive measurement, they were only missing over a 3-month period, just 1 or 2 measurements for most subjects. So it was incredibly surprising to how compliant people were with these measurements.
That's fantastic. Were any of the measurements that you actually received or obtained surprising to you, the type of data that you got?
Yeah, I mean, there were lots of interesting aspects to the data. I mean, I've got a slide here that shows all the impedances across all the electrode positions for all 15 subjects. But if we just pull out the data from, 5 representative participants in 4 representative electrodes, we could say, well, look, all recordings fell within normal limits. maybe we would expect that, given they're good users. But even within that, you've got some some subjects that are incredibly stable, whereas others have got some quite significant variability that doesn't seem to be affecting their overall performance, which is interesting. I've got another slide here that shows the electrode impedances across all 4 participants, and certainly in the apical electrode, the impedances seem to be slightly higher than compared to the other electrode position. This slide just compares the morning versus evening impedances, and although for some subjects there was some variability, overall there was no significant variance across the day, which is reassuring. From the ECAP result, we've got again, really good stability across all 15 participants. While some subjects, for some electrode positions, we couldn't get consistent recordings, for the vast majority we could get consistent recordings across all electrode positions, and at least for every subject we were getting some recordings at most electrode positions. On average, they were very stable across the electrodes. So unlike the impedances that rose the apical, in terms of the impedances being higher at the apical positions, they were pretty stable across the positions. The ECoG results, Paddy, were the most surprising. So this graph shows our ECoG results, and it's important to stress that we were not recruiting particularly hearing preservation subjects, but for most were, in our thoughts, profoundly deaf with little or no hair cell function, and yet we were able to record responses still in every subject at a minimum of at least one frequency, at least one time over the testing period. So I think there's just this remarkable amount of residual hearing that we don't really know too much about, and this sort of system can really for the first time show us what residual hearing we've got out there. So really exciting.
Fantastic. That is really encouraging indeed. And I suppose, do you see that maybe this approach, perhaps in a more refined way, being used in the future? This is part of a very, very interesting study, actually. But do you see some aspects of this being used? You referred to the COVID pandemic earlier on there. Do you see it being used in future, or even when things are much more normal?
Overwhelmingly, I just see suddenly the capability of the system can suddenly give us a window into what's happening in the health of people's cochlears, and not only for individuals who have had a cochlear implant alone, to kind of really assess, because whilst Patrick beautifully described some of the surgical factors that lead to loss of residual acoustic hearing, a lot of factors are not in our hands. They happen after our surgery, so post-operative. And for the first time, something like the AIM tablet could really give us a window into what's happening at what time point, what individuals, and potentially why. The other thing that you were alluding to that I'm particularly interested in is adjunctive therapy, and to really measure the safety and efficacy of those adjunctive therapies. We can't measure the cochlear health very effectively with behavioral techniques. We can't do that. It's just not sensitive or specific enough, nor really imaging is going to be sensitive or specific enough. And the cochlear array really gives us that wonderful window in conjunction with the AIM tablet that can really give us that idea about how safe, how effective these treatments are going to be.
Thanks, Doug. That's very interesting. I see really the two pieces of work that Patrick and yourself described as complementary. Patrick looking to, if you like, maximize cochlear health or minimize cochlear trauma during the insertion of the electrode, and we're looking at monitoring it in the longer term, and particularly if you're going to use a different therapy, which is really exciting going forward. Now, we're going to look at just briefly some work by Professor Joseph Mateus, who unfortunately couldn't join us today, as I said earlier, live. But we'll look at that. and then maybe have a quick thought on what he's doing.
So, Joseph, I know that you've been doing some innovative work with the recording of cortical potentials via the cochlear implant, a really exciting topic in research at the moment. Could you describe the type of work that you've been doing, please?
Yes, thank you. Yeah. You know that currently the objective measures today are efficient and very, very important to estimate the threshold levels or the audible levels and comfortable levels of the CI users. However, they are not providing information about the auditory functioning. So to complement the current objective measures, we have started working on recording directly from the CI the cortical evoked potentials as an objective measures, as the current objective measures like the ECAP and the ECoG, relying on the backward telemetry of the cochlear implant. So, of course, with the support of advanced bionics, we have developed a software that in principle does the same as the ECAP, but for longer duration.
Mm-hmm.
For longer duration. So for the last, I think, 2 years, we have started. And so far, we have been gaining data on CAP from several CI users. And in the current stage, what we have been doing is that we have been started by recording acoustic cochlear cortical evoked potentials, which means that we took CI users with residual hearing and we acoustically stimulate them and recording the cortical evoked potentials through the CI. Mm-hmm. In order to see if feasibility is okay, we have compared what have been recording directly from the CI to what has been recorded from scalp electrodes.
Uh-huh. Nice.
So the CI is doing two things. One, triggering an external EP system and getting the CIP through the scalp electrode. Simultaneously to that, we are recording the cortical evoked potentials through the CI only. And we are comparing them. Mm-hmm. We have been doing it for adults and children.
Right.
And I think that we have a very, very nice results.
Lovely. And that's the sort of nature of the diagram that you've shown us, really, that we have that system set up. And obviously, if it works well, it's a great deal simpler to make a recording via the cochlear implant rather than to have to attach scalp electrodes, and particularly to use something like a cap that is commonly used for them. So are you comfortable? How do the results that you've got so far compare with the EP machine?
So what we have been doing is, first of all, we are comparing the single channel EP, the evoked potential system, with the single channel of the cochlear implant. Uh-huh. And the cochlear implant, what we are doing, we are collecting the difference voltage from the apical electrode to the case. The case is the case of the implant, which is situated in the mastoid. Mm-hmm. So this is the difference voltage that we are recording and taking it back through telemetry, backward telemetry to the application, and we are processing it. Uh-huh. So far we have been collecting and have been shown that there is a great similarity, even it's very equal to the scalp recorded potentials. The similarity has been manifested in a variety of ways. First of all, we didn't find any significant differences between the latencies and amplitude components of the cortical evoked potentials. Uh-huh. The cross-correlation coefficients between the two wave morphology was excellent. And what's most important, that the repeated measures correlation between the each person to the scalp versus the CI was almost 1,
Wow.
which means that we are doing the same as the scalp recorded. Now, it took very, very short time. It took 3 minutes per 100 sweeps.
Mm-hmm.
It's very, very easy. It's, again, I'm saying it again, it's like doing the ECAP attached through the headpiece, and the headpiece is attached to a software. And the delivery is the delivery of the stimulus is through, of course, through the speech processor if it's electrical stimulation, and if not, it's through the acoustic stimulation through the EP system. So first, it's very in a short time, which makes it very, very clinical applicable, which make it very, very doable for children and for adults. And we know the correlations between what it can be gained between the cortical activity and speech and the CI outcomes. And we know that this is a very, very promising and efficient tool for the future with the cochlear implant.
Very, very nice. Now you've said, Joseph, that it's very easy to do. I know you've done a lot of work in order to optimize the recordings and all the stuff that needs to do in the background to reduce noise and artifact and so on. But do I understand that you really see this being clinically practical rather than, as it is right now, it's a research application?
Well, just to remind you that this is the first time that anyone has been doing such a recording directly to the CI.
Mm-hmm.
So far, they are using an external system with scalp recorded. And as we have said before, scalp recorded with the external EP system has a great limitation in the practical, yes, in the clinic practice.
Exactly.
So at the moment, we have proven feasibility. I truly believe that we have to improve and to show that there is a great clinical relevance of collecting this measure to the programming, to improve the electrical hearing, the perception of the electrical hearing of a CI user. This can be done only by a cortical measure, and hopefully that we can change the electrical hearing and focusing it individually to each CI user using the cortical evoked potentials. I want to remind you also that we know that neuroplasticity is a brain measure.
Yeah.
And the only way to access the brain measure is through a recording of brain measure. And the brain measure here, which is accessible, is the cortical evoked potentials. And for the first time, we have proven the idea that is doable, and hopefully with more research and more clinical application, we will come to a stage where we can apply it for improving the programming of the CI, especially in cases where the cooperation is limited. For instance, children, adults that cannot cooperate, and so on.
Excellent.
I want also to remind you that hopefully it will shorten the programming time in the future, because we will have a direct cortical measure. This is for the current stage. Yeah.
That sounds tremendously exciting. It's wonderful to see technology advance in this way. And, you know, both of us have been in the field for some time. Remember how the sort of more peripheral measurements that you referred to a little while ago, Joseph, became commonplace. Much easier to make. For example, I contrast it with if you can measure an ECAP rather than an EABR through the system. You might argue that the EABR is a more comprehensive measurement, but it's very rarely made. Sure, because of convenience. So your work here, I think, will help make these cortical measurements much more commonly made clinically. And anything you can think of that would make it easier to do for maybe less research-oriented people, a much more clinical type application?
Yeah. Well, today the system allow us to record anything up to 1,000 milliseconds, which means that all potentials that you know, ECAP, EABR, in principle, can be recorded through the CI currently.
Good.
Now, it is also present a very powerful and novel research tool to the whole idea of what electrical hearing is doing to the brain. Immediately, and I think in online. Today, I'm trying to see how much simple is just doing like you are doing ECAP. You put the headpiece, you press a button, the child is getting the stimulus, and we got the responses. Of course, we are only in the first stage. It is a very, very promising results, but we have to enlarge the population in order to be able to prove what exactly the clinical application that we can do. Can we change, for instance, a programming to the brain, through the CAP? Can we, for instance, rehabilitate or training a person through the CAP and so on? What we know that previous reports show that the CAP, especially the N1P2 or P1N1, is very close to the speech and language development in children. And there is a close correlation between the duration of the deafness, untreated duration of deafness, and the presence and the features of the CAP. So as you can see, there is a large, very large promising applications to the perception of the auditory stimulus to the brain, which can be done only today, only by external system and scalp recorded. Of course, I'm not saying, but it's not clinical practice for a large people with the CIU.
Not yet, but what you've talked about, and thank you for the work you've done in this field, Joseph. It sounds like it's going to open up another very useful clinical application where, as you rightly say, we get insights into the brain where we're actually going to hear, and also a raft of research applications too. So wonderful work. Thank you very much for sharing your experience and your passion for it with us. That's wonderful.
Thank you, Paddy. Thank you.
If I can ask again, both of you, having had a brief look at the work of Professor Mateus, how do you see the potential, maybe going forward, maybe starting with you, Patrick, for what's at the minute very much a research measurement, the assessment of cortical and high level potential via the implant?
Oh, I think we're at the very beginning of our journey here. We really don't understand fully what we are recording, what it means, and I hope very much that we will be able to develop both stimulation techniques, recording techniques, either from the electrode array or more centrally. And I think from the central pathways, which I think is also, from what I hear, extremely exciting. Yeah, but it's just an open book, really. We just don't know what we're going to find, and I think that's really very exciting.
Thanks.
I would echo that, Paddy. I think we are just beginning to find out what the capabilities of this system is. I think particularly trying to monitor the cochlear health and trying to correlate it with other more established measures. I think it's a really exciting time, and we, whilst there are definitely some applications in adjunctive therapies, I think there is a whole scope of the capabilities of the AIM system that we don't even know what we might be able to use this for yet.
Thanks. I feel that's very, very, those are nice comments. In some ways, I see it in a way that we saw objective measures such as the ECAP measurements some years ago. They opened up a new wave of research, but also very important clinical insight and clinical application. And I'm very hopeful that we'll see the same thing from this use of ECoG via tools like AIM. So that's great. I have also maybe to ask the two of you as two practicing surgeons, cochlear implant surgeons, The group in Hanover, Professor Leonard's, have recently published a little bit of work with the Slim J electrode array, where they used ECoG for monitoring, and they partially insert the electrode array and will really stop inserting at the point where it's no longer possible to maintain the ECoG signal. Could either of you give me your thoughts on how you see that?
In a UK healthcare system, I'm not sure that the need for potential revision surgery would be quite as easy as perhaps other healthcare systems. I think my only other big concern is, whilst we as surgeons think there's a lot of factors that are interoperative that may affect cochlear implant outcome in terms of residual acoustic hearing, I think there's an awful lot of factors that aren't in our hands and do occur later on. So I think you could then end up with the worst of both worlds, with a partial insertion and loss of residual acoustic hearing that happens later. So I think we perhaps at this stage need more information, and that's where the AIM tablet could give us that information as to why people lose their hearing and at what stage. But also, to say, you'd be very much dependent on your healthcare system being amenable to allowing you to reinsert and later day easily.
I would just add that it must be good to see so much confidence placed in the recording of the cochlear microphonic, which is fantastic from a very, very reputable.
I think so. I think, to be fair, sorry, Patrick. To be fair as well, I don't want to insult the UK system or indeed the German systems, but it seems that more hearing is being, more residual hearing type cases are being implanted in Germany clinically today than in the UK. It's much more, conservative or careful about providing implants, and therefore maybe the cases that are being considered there have a great deal more to lose. So I think I very much respect the answers that you gave. You're looking at trying to make sure that pretty well the electrode is deployed as carefully as possible, but at least today trying to fully deploy it as far as that can possibly be done.
So it simply remains for me to thank our three speakers from today. We had interesting and informative pieces of work being presented, both clinical and research. I hope that you found something interesting in each of those, and I can look forward to the future use of the AIM tablet that is currently leading to improvements in clinical practice, and I'm convinced will lead to both clinical and research applications in the future. So thank you for your attention. Hope you enjoyed it. Goodbye.
One of the issues I have is when I'm inserting the electrode array into the cochlea during implant surgery, there's no real-time feedback. I wish there was a tool that would help me monitor the cochlear functions interoperatively.
Yesterday I was working with a 2-year-old and a CI recipient, and it took me forever just to get a few points on the audiogram. For some of our harder to test patients, obtaining reliable results can be so time-consuming and difficult.
At Advanced Bionics, we are committed to helping you serve your patients. That's why we developed the AIM system.
AIM solves all my problems.
Oh, AIM is saving me a lot of time.
AIM is a fast, objective, and convenient tool during CI surgery and after. AIM uses the proven method of ECoG to provide convenient, real-time monitoring during electrode insertion. AIM can perform objective audiometry quickly and without requiring patient cooperation. AIM can even be easily used to conduct a host of other objective tests, such as NRI, ESRT, and impedance.
AIM is making it much easier to test my CI patients.
I use AIM for all of my CI surgeries.
Contact your Advanced Bionics representative to schedule a trial with the AIM system at your next surgery.